It's a great pleasure to introduce Dr. Bilquis. She's the first speaker in the second session. Dr. Bilquis is the head of Geriatric and head of the medical unit in Jahra Hospital. She had been fellowship in American board. She has been working extensively for geriatric population in Jahra and before in USA. Welcome, Dr. Bilquis.
My topic today is screening guidelines in geriatrics. And it's not an easy topic because it's very, very vast, and I'm going to try to do justice to it in the 20 minutes that we have, inshallah. So let's get started. Why is it important to have screening in guidelines? So as the saying goes, an ounce of prevention is worth a pound of cure. As we all know, prevention is much, much better than cure. So that's what this leads to, screening guidelines. So if we go ahead and just look at guidelines in general, we have primary, secondary, and tertiary prevention. Of course, primary prevention is when the disease does not exist and we are preventing initiation of a disease. Typically, it would be immunization, for example. Secondary prevention, when the disease is present but not known, or the person is asymptomatic and we are trying to detect it. And most of our screening guidelines fall in this category of secondary prevention. And that is to prevent the disease from progression. Tertiary prevention is when the disease is already present and we know, and we are trying to avoid complications from the disease. For example, coronary artery disease as a complication of hypertension, diabetes, or macrovascular complications from diabetes. So for a screening to be effective, we have 4 things that we need. Number 1, the condition should be common, so it should be prevalent. Number 2, it should cause significant morbidity and mortality if left untreated, so we know which these conditions are. It should have a preclinical stage which will allow detection, and the 4th would be it should have an effective treatment to make a difference. So let's go ahead and look at geriatric screening guidelines as to why they are important. As we know that the life expectancy has increased dramatically. Early 1900s, we had 47 years approximately. Now we are up to 79 years, and we are expecting further increase. And in 2050, we are expecting that 20% of the world population will be above 60 years of age. So, and that would be about 2 billion people or so, and 1.6 billion of them will be in developing countries. So this shows us the importance of having geriatric guidelines. The fact is the chronic illnesses have increased because of the life expectancy having increased. Infectious diseases have dramatically decreased as a cause of death, and chronic diseases like cancers, coronary artery disease, strokes have been the leading cause. So our goal should be to find a proper screening for these so we can manage them. Now, age alone should not be a sole determinant of screening, like a 65-year-old versus a 75-year-old. Age itself should not be a determinant. Rather, multiple factors are determinants. We have lag time for different screenings. For example, lag time for colon cancer, approximately 10 years to make a difference. So it's pointless to screen a person who has a life expectancy, a good life expectancy of only 5 years. It wouldn't make a difference for that person. Whereas, so it's not just the age alone, it's lag time, it's also the person's comorbidities or the health status of the person that is important. And also the priorities of that person in order to do that screening. We have to keep that in mind. Now, also the screening should be evidence-based, and they should preserve function, it should maximize the quality and quantity of life, and we should follow the guidelines, which are ever-changing, as we know. So it's hard to keep up with these guidelines, but we will try to do our best. So let's get started. The first and foremost would be lifestyle modification, which is the best thing. And in here we have activity. Physical activity decreases all-cause morbidity and mortality, as we know. We have various activities out of this: aerobic, weight-bearing, flexibility, balance. Balance improves or decreases the risk of falls. conditioning is better with aerobic activities. Weight bearing improves muscle strength, and flexibility will increase the range of motion. So all of them have their own benefits. Tobacco use. We sometimes neglect this fact. Oh, he is 80-year-old, he has smoked all his life, he cannot quit now. But no, that's not true. I mean, at any age, quitting smoking is helpful. So the patient should be counseled about this. The fact is that the older people don't smoke. The number of smokers in elderly are less than the young adults, but they have usually smoked for a longer period of time, over many years. And so the morbidity from that is more in them, in terms of cancer, COPD, and other illnesses from the smoking. So we should counsel them and advise and assess and help them quit. Nutrition in general. Both extremes, malnutrition and the other extreme. So for this, what is ideal is serial weights. If there is an involuntary loss of more than 10% of the person's weight in a year, that is a red flag to look into malnutrition issues or issues that are leading to that. Maybe it is depression, maybe it is dental problems, I mean, whatever. There are screening tools that can be used. I cannot go through all those because we are going to be brief about each screening only. Vitamin D, as we know, very important. It's not necessary to check the level, but giving vitamin D 800 to 1,000 units with calcium to the elderly helps them decrease the incidence of falls, fractures, and some other things which are still in investigational stages. It is not that beneficial to give high doses of vitamin D intermittently as it is to give regular doses daily. It helps in preventing falls more than the high doses that we sometimes tend to use when there is a deficiency. Multivitamins in general are not recommended routinely, but could be used in people who are malnourished or have poor oral intake or have specific deficiencies of those vitamins. Immunizations, okay. This is also something we tend to neglect. Now, tetanus, we don't think about it, but a booster of tetanus every 10 years is recommended in above 65. In fact, they say even one dose of tetanus toxoid after age 65 is sufficient. And nowadays, there has been since 2010 pertussis to be added to that because elderly who are in contact with infants, they should specially get a dose of tetanus, pertussis, and diphtheria together. Influenza, majority of our deaths from influenza are in the elderly. So it's very important to have the inactivated influenza vaccine annually. High dose vaccine is actually recommended, but if not, at least the regular inactivated one dose annually is recommended. Pneumococcal vaccine, the one we have available in Kuwait is the second one, the 13-valent conjugate vaccine. One dose of that is sufficient and does not need to be repeated. The other one, the 23 polysaccharide vaccine, usually is repeated after a minimum of 5 years or more. But the one we have is 13, but it also decreases the deaths from pneumonia. So important. Again, herpes zoster. Increase in herpes zoster in the elderly, 8 to 10-fold rise. The reason being cell-mediated immunity is less. So a dose of the herpes zoster, just one dose, initially FDA approved it for people above 60, and now they have made it above 50. So above 50, one dose of the live attenuated herpes zoster vaccine significantly decreases morbidity from zoster rather. It's not the rash itself, of course the duration of rash also, but post-herpetic neuralgias, encephalitis that we see, ophthalmic herpes, nerve palsies, all of these are decreased by having a dose of a zoster virus. And of course it has to be an immunocompetent person because we cannot give live attenuated to an immunocompromised elderly. Aspirin for primary prevention, I'm not going to spend too much time on this. It's like the younger people, it is known to decrease the risk of non-fatal MIs and colon cancer, but does increase the risk of bleeding, so that has to be kept in mind, especially the gastrointestinal tract bleeding. It does help the overall mortality. Most beneficial between 50 to 69 years of age, and people who have a 10% 10-year cardiovascular risk, as we can calculate from the different tools that we have available, and their life expectancy should be 10 years. Cardiovascular screening, we have blood pressure as the foremost a prevalent disease in the elderly, and it's a leading risk factor for coronary artery disease, strokes. So screening every visit is ideal, at least annual screening. Now, just by screening in the office, it might not be sufficient. We might need to have ambulatory BP monitor, which is recommended, and also home monitoring if ambulatory not available, because we would take off the factor of white coat hypertension there, which sometimes plays a role in false diagnosing people. Treatment of hypertension would decrease all-cause morbidity, mortality, as we are aware. The goals for the elderly, the target blood pressure is different than the younger people. 150/90 is sufficient, because lower targets than that is supposed to cause more harm than good, especially hypotension, falls, syncope, renal impairments, electrolyte imbalance, multiple things. So unless a person is high risk with stroke, TIA, or chronic kidney disease, their goal should be 140, otherwise 150/90 is a sufficient target. In elderly, two specific things to be kept in mind: orthostatic hypotension and postprandial hypotension, which sometimes occur together. Postprandial because of the splanchnic vasodilatation, and postural hypotension also with standing, and this leads to falls many times. So this needs to be measured in the clinics as we follow our patients. For postprandial, there is no specific treatment, probably small meals, avoiding certain kind of drugs which cause more of this problem. Isolated systolic hypertension, another issue in the elderly, where the systolic blood pressure is more than 160 and the diastolic is less than 90. Now, why this is important is because it's a direct correlation with coronary artery disease. Systolic directly proportional and diastolic inversely proportional, because as we know, the coronary perfusion happens in the diastole. So the lower the diastolic, especially less than 60, and the higher the systolic, would be a higher predictor of coronary artery disease. So these have to be kept in mind as we monitor our patients regularly. So it's a J curve, actually. So as we go lower on the BP, the benefit of it is less in the elderly. Further, lipid screening, I'm not going to talk too much about it because we do have a talk by Dr. Aziz on this topic, but there is no upper age limit to screen for lipids, and the treatment is per the patient's risk factors and his health status. If there are previously negative screens, we could stop screening at age 65. Abdominal aortic aneurysm, now this is recommended as a one-time screen for any male who has ever smoked between ages of 65 and 75. This helps morbidity, mortality from AAA rupture. If it's a non-smoker male, anybody with a family history of AAA aortic aneurysm would need screening with one-time ultrasound, non-invasive, but helps decrease mortality in these patients. If the aneurysm size is twice the normal, needs to be treated. I won't go in the details of that. Ladies have it less commonly, so it's not recommended in women. Diabetes screening is not much different from the younger population. It's the same rules that apply. Anybody with a BMI of more than 25 or history of hypertension or dyslipidemia should be screened for diabetes with a fasting blood sugar or an HbA1c. Even a random blood sugar of 200 or 11.1 would confirm diabetes. If there are no symptoms, one needs to repeat the test. If there are symptoms and any of these are positive, it confirms the diagnosis. And then early diagnosis and treatments prevents, as we know, micro and macrovascular complications from diabetes. functional screening, something that we need to do in the elderly that we normally don't do in the younger population. I'm just trying to put forward things that are different here. So we have ADLs, activities of daily living, and these are basically taking care of oneself. So if a person can do these activities, bathing, they can take self-care. Instrumental activities of daily living, again, there are different scores here, and in this would mean that the person is able to maintain a household. This would involve, in addition to ADL, using the telephone, for example, managing finances, doing their laundry, taking their medications. These things come in the IADLs. And then the advanced ADLs are more advanced, like driving, and that needs a higher functioning person. 5, okay. The others got more time, so you and I should get more time. So fall risk and mobility issues important because 30 to 40% of the community elderly fall. And as we know, fall is a major risk for morbidity, mortality, leads to a lot of problems. An easy screening test in office is timed up go test. In this, you would ask the person to get up from a chair, walk about 10 feet or 3 meters, come back and sit down on the chair. If that takes more than 20 seconds for the person to complete, this means that there is an issue with mobility and balance. So further assessment should be done in that case of issues like vision, orthostatic hypotension, medication history, gait problems, balance issues. Cognitive screen. In cognitive screen, usually a patient with mild cognitive impairment would go about their normal function without having a problem. When it is more than that, it is when the problems start appearing, and usually it is by the informant who reports that there are many memory problems, complex tasks cannot be done, there are issues with orientation. So then in this, the best screening I would say is, of course, mini-mental is well validated, but sometimes it takes longer time and it's hard to do it in the clinic. So a mini-cog screen, and that just involves 3-item recall of 3 items, and clock drawing of a particular time that we would tell the person. If the patient is able to do that, usually you can say that they're cognitively okay. Depression unrecognized leads to cognitive symptoms, leads to functional symptoms, leads to somatic complaints, sleep deprivation, fatigue, various things. So 2 questions could be asked very easily. In the last 2 weeks, have you felt really down and depressed? If an answer to that is yes, it's an indication. The second question could be, have you not had any pleasure in your day-to-day activities? These are 2 easy questions which have good sensitivity, though not very high specificity, but it helps us in detecting these patients. And then if positive, then we have the geriatric depression scale, which is a longer scale. Thyroid scan, there is controversy about this, whether thyroid function should be checked regularly, but if there are any symptoms of hypothyroidism, of course, one should have a low threshold of checking it. Also, if there is a history of any autoimmune disease, radiation to the neck, or whatever that would lead to that problem, it should be checked. Coming to cancer screening, we have 4 cancers that we will talk about here. Now, cancer screening in general is recommended for this age group, and we will go through these screenings, but the bottom line is there should be a life expectancy of at least 10 years for a person to get screening for these malignancies. So colorectal cancer screening, important. It decreases the mortality with this specific cancer by 20 to 30%, and it is recommended in 50 to 75-year-olds. Depends on which test you use. If you do a colonoscopy, which is actually the preferred test, it would be every 10 years. If it's a sigmoidoscopy by itself, it would be every 5 years. If it is a virtual colonoscopy, it would be 5 years. And if it's just stool sampling for blood, that would be annual. Colonoscopy, as we said, is the procedure of choice, not sigmoidoscopy, because we are not looking at the proximal colon, where sometimes this malignancy exists more in the elderly.
2 minutes.
Dr. Mohsin, you're not properly looking at the time, I think. So, of course, decision on this will depend on the comorbidities. I will go quick. Breast cancer screening also recommended between 50 and 74 years. More beneficial for people between 60 and 69 because in this you have the highest benefit where 21 deaths are avoided every 10,000 screened. So this age group is the one that benefits the most, and this should be done once in 2 years with a digital mammogram. Breast exam by itself is not enough. Prostate screening, let's go through quickly, not recommended, except for if there is a strong family history between 50 to 69 years of age after discussion and informed decision making. Very important because sometimes it can lead to more morbidity than good. Lung cancer screening, well, pulmonologists are here, but basically it is recommended that anybody who having a more than 30 pack year smoking history should get screened with low-dose CT. Now, it is between ages of 55 and actually 55 and 80 as recommended by USPSTF, but this is based on the National Lung Screening Trial that showed benefit of decreased morbidity of 20% with the screening. So, and once the patient has quit smoking for 15 years, they could stop screening for this. Cervical cancer, not important. At age 65, it's negative screens, you can stop. Osteoporosis, here, various guidelines, but more than 65 in females and more than 70 in males should get a DEXA scan. If DEXA scan shows a T-score, which is osteopenic range from -1 to -2.5, they should be screened every 2 years. Now, if there is osteoporosis on it in which the bone density shows less than T-score of less than -2.5, they should get treatment. The other reason to treat would be a compression fracture of the vertebrae by itself without having a positive DEXA scan. They should also be treated as osteoporosis or a hip fracture or a low trauma fracture. All these people will qualify. Vertebral imaging is recommended in osteopenic patients with these different things. I don't think I can say it all because they're going to stop me. So we will just say that patients with osteopenia should get vertebral imaging depending on their T-scores, and this is to detect compression fracture so that they can be treated. FRAX tool developed by WHO in 2012, which is used for osteopenic patients between ages of 40 to 90 to calculate their 10-year risk of getting a fracture. And if the risk is more than 20 for major fracture or more than 3 for hip, they should be treated. Evaluate for other causes, secondary causes. The other things, last slide, to be seen in the elderly in the office is incontinence, which they won't tell you unless you ask them. It can be treated. Vision, which should be evaluated. Macular degeneration, cataract, all these different causes. Hearing, whisper test. From the back, you would whisper and see if the patient hears. Very easy to perform. Polypharmacy should be every visit, every point of contact with the patient, you must review the medications, drug-drug interactions and side effects. And driving. Last but not the least, accidents on the road do happen with elderly drivers being there who are not competent enough to drive, mainly vision, hearing, psychomotor skills, and cognitive decline. So I hope this has helped people where we have these screening guidelines. Thank you.